Hello class, this is Miss Smedley. Today we're going to be talking about hematology. The hematologic system is important for oxygenation and tissue perfusion because the blood itself is one of the oxygen delivery systems. All systems depend on blood for oxygen perfusion. All problems of the hematologic system affect the total body health and well-being. So if you'll bear with me, I will pull up my PowerPoints here and we'll get started on this subject. Okay, as you all know, that the bone marrow is the origin of all the blood cells. The stem cells are precursor cells for all the blood components. The stem cells are baby cells and they can differentiate into any cell that your body requires at the time. You also have extramedullary hematopoiesis, which comes from the liver and the spleen. It also produces blood cells in patients with diseases that cause bone marrow destruction. Now you have several different types of blood cells. Your red blood cells are your erythrocytes and your reticulocytes, which are immature red blood cells. So when you would see an increase in your reticulocyte cell count on your laboratory work, you would automatically know that your body is kicking out immature cells because it's needed for your red blood cell levels. Your white blood cells are composed of granulocytes and agranulocytes. The granulocytes have granules in their nucleus that is visible on microscopic exam. They are composed of the neutrophils, the eosinophils, and the basophils. They all end with phils, so remember the granulocytes are the phils. Your agranulocytes are monocytes and lymphocytes. They have cyte at the end of them, so when you hear the word cyte, you will know that they are monocytes and lymphocytes. The monocytes are your macrophages, which are little bitty Pac-Men that go around gobbling up all of the bacteria and viruses that are in your blood system. Your lymphocytes are the T cells and the B cells, and then there are natural killer cells, and those will be discussed more in the immunology with Miss Lindsay. Your body is also composed of thrombocytes, which are your platelets. Your erythrocytes transport oxygen and carbon dioxide to and from the cells. They live about 120 days. They break down in the spleen. Your book has your typical normals, and I have listed here 4.6 to 6.0 for males and 4.0 to 5.0 for females. Some of the laboratories will vary just a little bit in this. So after you get out there and get to working, you need to be familiar with what your hospital goes by and the lab. Hemoglobin accounts for approximately 95% of the mature red blood cell composition. Your reticulocytes are synthesized hemoglobin after loss of the nucleus, letting the red blood cells continue to be released in the circulation. Normal reticulocyte count is 1% of the circulating red blood cells. Reticulocyte counts go up with increased damage for red blood cells, like bleeding or possibly with diseases. Now let's move on to the leukocytes. White blood cells generally are not present except for in very small amounts in the bloodstream unless they are needed for defense against infecting organisms. The white blood cells are separated in two major categories, like I said earlier, the granulocytes and the agranulocytes. Leukocytes have a longevity of a few hours to a few days. There are approximately 4,500 to 10,000 leukocytes per microliter of blood. The lymphocytes compose 25 to 35% of all your leukocytes. Immature B cells are produced by bone marrow and released into the bloodstream upon interacting with the antigens or protein. The B cells become activated into plasma cells, which are responsible for the production of antibodies and immunoglobulins. Basal cells make up approximately 0.4 to 1% of the total white blood cell count. They play an exceedingly important role in allergic reactions. An increase in higher percentages of basophil in the blood may indicate an inflammatory condition somewhere in the body. Your neutrophils make up approximately 50 to 70% of the leukocytes and are primarily responsible for maintaining normal host defense against pathogens and are the first leukocytes to respond to organisms that invade the body. The neutrophils respond more quickly to infection than do the monocytes. However, when monocytes reach the site of infection, they arrive in a much larger number and can phagocyze many more microbes than neutrophils are able to. Eosinophils make up approximately 1 to 3% of the leukocytes. They liberate the heparin and the antihistamine and the serotonin in allergic reactions and intensify the inflammatory response. A higher than usual percentage of eosinophils in the blood may indicate a parasitic infection somewhere in the body. Monocytes are the largest of the white blood cells and make up 4 to 6% of the total leukocyte count. Function is to engulf and digest their microbes and other foreign substances. Monocytes migrate from the blood to various tissues where they mature into macrophages. A macrophage, also known as a scavenger, can either stay in one tissue or migrate to other organs via the lymph tissue. Macrophages are activated when their membrane comes into contact with an antigen. The phagocytic white blood cells have a lifespan of 2 to 4 months. Thrombocytes are your platelets. They have many granules but no nucleus, and they live 5 to 9 days. They are approximately 150,000 to 400,000 platelets per microliter of blood. Glycoprotein 2B and 3A binds fibrin and forms the bridges between the adjacent platelets. When activated, a process is called aggranulation. Let's go on to the lymphatic system. Lymphocytes that produce antibodies include your T cells, your B cells, and natural killer cells, which we will see as NK cells. B cells are released as immature cells into the bloodstream and interact with antigens or proteins as they become activated. Lymph fluid is formed from the natural diffusion of fluid across the semipermeable cell membrane of blood vessels and peripheral tissues into the interstitial spaces. The main function of the lymphatic system is to collect and return interstitial fluid and thus to help maintain your fluid balance. They defend the body against diseases by producing lymphocytes, and it absorbs lipids from the intestine and transport them to the blood. Your lymph nodes are small aggregates of lymphoid tissue located along the lymphatic vessels throughout the body. The function of the lymph nodes, I forgot to move my cursor. Lymph nodes are small aggregates of lymphoid tissue located around the lymphatic vessels throughout the body. The function of the lymph nodes include removing foreign materials from the lymph before it enters the bloodstream and acts as the center of proliferation for immune cells. The lymph nodes function as filters and reservoirs, acting as incubators for white blood cells. The spleen stores blood, about 20 to 40 milliliters of red blood cells. It removes old blood cells, and as one of the primary roles, it filters and destroys antigens before they can enter the systemic circulation. Most notably, the spleen is able to catabolize the hemoglobin released from decaying erythrocytes and return the iron component, the heme component, back to the bone marrow. The patient suffering from hematologic disorders that result in a high turnover of erythrocytes frequently presents with an enlarged spleen. Additionally, the spleen stores approximately 1/3 of the total volume of platelets. The liver, as it relates to hematology, the liver stores blood and plays an important role in the clotting mechanism of blood. The liver produces the coagulation factors that are necessary for fibrin clotting. In addition, the liver can produce anticoagulants so that there is not too much clotting going on in the body. Your normal clotting mechanisms, hemostasis, is defined as stopping the blood flow. The balance between the force that causes blood to solidify or to remain fluid is very delicate, and it involves several interacting systems. Primary hemostasis is characterized by vascular contraction, platelet adherence, and formation of soft aggregate plugs. After injury occurs, the initial temporary response is vasoconstriction. Vasoconstriction, it slows the blood flow and thereby enhances the platelet adhesion and activation. Primary homeostasis is short-lived. The immediate post-injury vascular constriction abates very quickly, and the flow is allowed to increase again. That soft plug that is formed can be sheared off and can possibly cause an embolism. And then you will have secondary homeostasis. Secondary is responsible for stabilizing of the soft clot and maintaining your vasoconstriction. It's initiated when the cascade system of coagulation is activated by substances released at the time of injury. The intrinsic and extrinsic pathways result in the conversion of prothrombin to thrombin. Thrombin is necessary for fibrinogen to be converted to fibrin, which is the stabilizing protein that anchors that platelet plug to the site of the injury and prevents any further bleeding. Coagulation factors in the cascade system. The coagulation factors are generated by the liver cells except for the factor VIII, or at least the von Willebrand's portion of the factor VIII. Which is produced in multiple organs, possibly the endothelial cells and the megakaryocytes. Okay, both factor VII and factor IX will promote cascade reactions, eventually activating the factor X. Your factor X, along with factor III and factor V and calcium and platelet thromboplastic factor, which is the PF3, will activate your promin activators. The prothrombin activator converts prothrombin to thrombin, which converts fibrinogen to fibrin. Fibrin initially forms a loose mesh, but then the factor 13 causes the formation of covalent cross links, which converts fibrin to a dense aggregation of fibers. The platelets and the red blood cells become caught in this mesh of fibers, thus forming the blood clot. In other words, it looks like a very slow, loose weaved material. Just like if you're a sewer or a seamstress, you would know that the material can be very loose weaved, and the more blood that's caught in there, and the more fibers there are, the bigger your clot's going to be. Okay, platelets and red blood cells are caught in this mesh of fibers, and that's what forms your stable clot. If you would, you can look in your book on page 1707. They have the coagulation cascade for you, all printed out in a good graph. It might make it easier to understand for those of you that are more visual learners. Now let's move on to, first before we move on, let's go back to hereditary bleeding disorders such as hemophilia. It can cause deficiencies in your clotting factors that are involved in that clotting cascade, and also identification of the intrinsic pathway versus the intrinsic pathway of what factors are involved in each is important, because this information has implications for your laboratory test and medications that are going to be ordered for your patient. Okay, now let's go on to our taking the patient's history. Many hematological conditions cause few symptoms. The use of intensive laboratory tests is often required for the diagnosis. Therefore, a thorough history is also going to help you in your the nursing to identify symptoms related to abnormalities in the hematologic system, as well as their current and potential problems. The biographical and demographical data that you collect, the assessment of biographical and demographical data includes information regarding their age, their race, their gender, their ethnicity, and all of these factors can affect the susceptibility for some hematologic disorders. Okay? You're going to find out what your patient's chief complaint is. The current issue is the focus of why the patient is being evaluated. Unless this patient has already had some known problems with hematology to them, known problems to them, they probably will not have any knowledge of the hematologic system, and the patient will not know that a hematologic problem exists. A chief complaint can tell the nurse in the patient's have them tell the nurse in the patient's own words what the problem is and what the patient is currently experiencing. Also, it's important for you to determine the patient's own perception of their health status in order to determine if the patient has developed a plan for future health promotion. In their presenting symptoms, patients that are having trouble with erythrocytes or the red blood cell component of the hematologic system usually present with symptoms of fatigue or weakness. Okay, and shortness of breath is another common symptom that they present with. Patients that are having trouble with their white blood cell count or their leukocytes, neutrophils, or any of the white blood cell components, they usually present with an increased episode of illnesses and fevers. And patients who present with unusual bleeding may be having problems with their platelets and their thrombocytes and with their clotting factors. You want to go into their past medical history, find out about surgical procedures and how, because several surgical procedures can affect the functioning in the hematologic system. You should discuss wound healing with them. Did they have any complications from their previous surgeries? Any abnormal bleeding that they might have had from their past surgeries or injuries? Diseases that involve any of the hematologic organs can result in a hematologic disorder, such as cancer of the bone marrow, any kidney disease can cause a decrease in the erythropoietin production. This hormone is produced by the kidneys, and it promotes the differentiation and production of red blood cells in the bone marrow. Surgical manipulations can also affect the hematologic system, especially if it is a component of the hematologic organs, and if the surgery might cause some deterioration from consequences like a gastrectomy, a cholecystectomy, a splenectomy. All of these would warrant a more extensive follow-up. Family history, disorders that have familial patterns to them, like genetic information, offer clues to possible hematologic problems like your sickle cell anemias. Can be found in mostly in African American backgrounds. There's also thalassemia, which is often seen in Mediterranean background. Hemophilia can be seen more frequently in Caucasian males than you would see it in African American males. But then there's Tay-Sachs disease, which is found primarily in Jewish people from the Central and Eastern European descent. Also, you can see the Tay-Sachs in the French, Canadian, Cajun heritages as well. So, as you can see, these would all be important for you to find out where their family history is coming from. They can also result from similar environmental exposures or behavior modeling within the family. A patient whose family engages in smoking and poor eating habits are not they're not very active, or they're more prone to engage in similar behaviors as their family members have. Never make assumptions about a patient's genetic heritage. You should always ask that patient about their background. Your book has a very good cultural considerations box for you on all of these chapters that we've been covering and that we will cover. Also, you will see a very interesting box on page 709 on risk factors of drug medications that affect the hematologic system. These are important for you to know as well. Okay. Other risk factors that can alter the hematologic system can come from a variety of sources, like the medications, diseases, behavior patterns, family history, and surgical interventions. Social history, you want to identify potentially harmful habits or activities that your patients might have, such as smoking, poor diet. You want to know, do they live alone? Do they live with others? If they live with others, who are they? You need detailed information to determine, and maybe you can identify some risk factors that the patient is more prone to hematologic disorders and complications from those risk factors. Now let's go into the physical examination of your patient. A complete physical exam is required to thoroughly assess the effects of hematology system dysfunctions. Both blood cells affect because blood cells affect every major organ and body system, only a comprehensive examination can ensure that all possible derangements are identified. Inspection. When you inspect, you want to observe the patients who are short of breath, if they're fatigued, if they exhibit any poor stamina or poor mental acuity. They can be at risk for either anemia or infections. Fever is a very serious sign that warrants prompt attention, even in the absence of other clinical signs. A patient who is neutropenic, which means they have a decrease of their neutrophil supply, fever is often the only observable indication that they have an infection going on. Skin. Changes in skin color are often indicated with erythrocyte disorders, such as anemia. You're going to see some pale. There'll be loss of pallor. They'll have liver failure. You're going to see they're yellow or they're jaundice. When they have polycythemia vera, they're going to be pink and flushed. When they have a rapid breakdown of the red blood cells, you're going to see that they have a dark brown tint to their skin. Okay? Platelets and clotting derangements often produce tiny capillary bleeds that manifest as petechiae or purpura or ecchymosis that you can see on these patients' skin on physical examination. So you need to pay very close attention to what their skin looks like. The head and the neck, you want to assess the gums, the lips, the tongue, the teeth. All of these you want to check them for tenderness, pallor, bleeding, changes in the saliva, inflammation, redness, ulcerations. Pernicious anemia and iron deficiency anemia can produce a characteristic smooth tongue texture, and they'll have pale gums. The lymph node enlargement or tenderness, especially in the submaxillary, the tonsillar, and the subclavicular regions, can be seen in these patients. You want to check their eye sclera for color and for swelling. These can be signs of liver disease as well. You want to check their chest next in your physical examination. The heart is a sensitive indicator of any abnormalities. You can see an increased rate or tachycardia. It can be in a response to infection or to anemia, either one. Lymph nodes in the mid-sternum or in the axilla will be enlarged and tendered with infection, lymphoma, and other metastatic cancers. So you'll want to be checking those. In your abdomen, an enlarged spleen or splenomegalia, or the liver, hepatomegalia, is a general indicator of increased blood cell destruction, the cause which must be identified by you. Liver tenderness may be associated with clotting system abnormalities. and fewer blood studies are warranted whenever a complaint of abdominal tenderness is, and further blood studies, are warranted whenever a complaint of abdominal tenderness is found. Now let's talk about your labs and your diagnostics. You were assigned and you will be responsible for reading Chapter 2 in your lab book, your laboratory test and diagnostic procedures for nursing diagnoses. I will not be covering that with you in this lecture. Please make sure that you read that and go through it thoroughly. We're going to be talking about laboratory work as far as your med-surg book goes. The total red blood cell count is reported as red blood cells 4 to 6, depending on your gender and your ethnicity. Increased amount, physiological increases in the red blood cell count occur with living in high altitude and after increased physical training as a response to increased need for oxygen. You need to keep that into mind as you are talking to them about their social and their physical activities earlier. If you have someone that has recently moved here from, say, Wyoming, then you know that maybe they have a little higher red blood cell count. Or if you have someone that's in training for a marathon, they might have a little higher red blood cell count. And that would be normal for that person. You will see also an increase in the red blood cell count with polycythemia vera and chronic obstructive lung disease, and in some children that have congenital heart failure or heart disease that has cyanotic problems. And this increase in the red blood cell count will be in response to the chronic hypoxia that person has undergone. Decreases in red blood cell counts can be caused from abnormal loss of erythrocytes, in other words, bleeding, destruction from the red blood cells, lack of needed hormones or elements for the production of erythrocytes, and bone marrow suppression. Let's talk about hemoglobin, which is part of your red blood cell. It's measured in grams. It's the functional protein of the red blood cell that enables the red blood cell to carry out its primary function of oxygen transport. Hemoglobin is reduced in the case of nutritional deficiencies, bleeding, anemia, or hemodilution. Volume depletion or dehydration or polycythemia vera in turn causes hemoglobin to increase. Now let's talk about hematocrit. Your hematocrit values represent the percentage of hemoglobin in a given volume of whole blood that is occupied by packed red blood cells in a container of hemoglobin, or the concentration of hemoglobin. It is highly susceptible to fluid status changes, such as dehydration. If a hematocrit value is not reported, it is estimated by multiplying the hemoglobin by 3. Okay? Now let's talk about some of the more differential parts of the complete blood count, such as the mean corpuscular volume, or the MCV. The MCV is, if it's less than 80 micrograms per micrometers to the third power, the erythrocytes are microcytic. In other words, they're smaller than normal. Microcytic This occurs with iron deficiency anemia, lead poisoning, and thalassemia major and minor, which we will be talking about a little later. If the MCV is greater than 98, it indicates that the erythrocytes are larger than normal. Macrocytic red blood cells occur with liver disease, pernicious anemia, and folic acid deficiencies. Anemia due to acute blood loss results in normocytic anemia. Okay, let's talk about the MCH now. MCH is the amount of hemoglobin on one cell. The MCHC is the proportion of each cell that is occupied by hemoglobin, indicating efficacy of interaction with the hemoglobin molecule with the erythrocytes. Iron deficiency anemia is the most common cause of a hypochromatic anemia. When you have your erythrocytes have a normal number of hemoglobin, it is called a normochromatic. When there is a decreased color, it is called the hyperchromatic. And when there is an increased redness in the blood, it is a hyperchromatic. The MCV, the MCH, and the MCHC are measurements used in the classifications of anemia. The red blood cell distribution width, or the RDW, is a direct measurement of the consistency of the red blood cell size. The shape of the red blood cells is highly influenced by the configuration of the hemoglobin molecules. Diseases such as sickle cell anemia and thalassemia, both diseases of the hemoglobin, result in various shapes of the molecule. An increase in RDW indices is relative heterogeneous population of red blood cells, indicating the presence of either abnormal or immature cells. The RDW is useful to differentiate the various types of anemias. Please be aware of your safety alerts that are in your chapter. A drop in the hemoglobin level below 10 is a serial decrease in hemoglobin on consecutive reports may indicate anemia and should be reported to your healthcare provider immediately. Now let's go to talk about the leukocytes, or the white blood cells. Leukocyte evaluation can be summarized by the white blood cell count value, which is a normal of 4,500 to 10,000 cells per microliter. The neutrophils, like I said earlier, are the first responder cells, and they are responsible for the initial destruction of foreign antigens and initiation of immune response cascade. However, your total neutrophil count is a summary value that combines immature, which are blasts, juveniles, which are bands, and fully mature stage of neutrophils. Only the fully mature neutrophils, and to some degree the juvenile subpopulation, are useful in defense mechanisms. The total white blood cell count increases, but the rise is due to the proliferation of juvenile cells. It's called a shift to the left, and it should be reported to your healthcare provider immediately. In other words, a healthy individual, this shift to the left may be an early sign of otherwise undetected infection. If the total white blood cell count remains within normal limits or even slightly below normal and a shift to the left occurs, the patient may be left with insufficient host defenses. This can occur with bone marrow disease, immune system insufficiencies, or immunosuppressive therapies like your chemotherapies. Okay. Your absolute neutrophil count is usually a measurement revealing the proportion of white blood cells that can be utilized in first response immune interactions. To calculate the ANC, add the bands and the neutrophils and multiply by the total white blood cell count. Values greater than 1,500 indicate normal immune defenses. The white blood cell differential is a determination of each of the 5 types of the white blood cells in 100 white blood cells. Okay? A decreased number of the neutrophils indicates that the patient is at severe risk for infection and without sufficient defenses to prevent sepsis. You need to immediately assess that patient for signs and symptoms of infection, initiate any appropriate interventions, and report it at once to the physician. Platelet evaluation. The platelets count is usually an indicator of bleeding risk because the platelets are responsible for the initiation of the clotting cascade. Normal values range from 150,000 to 400,000. You will see an increase in the platelet count or thrombocytosis occur with malignant tumors, especially if it's a metastatic lesion, as well as with your polycythemia vera and splenectomy. Low platelet counts or thrombocytopenia can be idiopathic. It can be related to cancer due to autoimmune disease or as a result of a viral infection. Low platelet counts are also common in AIDS patients. Platelet levels below 30,000 indicate that the patient may be in imminent risk of internal bleeding, especially cranial bleeds. In the event that this is what is going on with your patient, you need to immediately report it to your provider and implement any bleeding precautions that you are instructed to implement. Coagulation studies. A variety of coagulation studies are utilized to identify individual insufficiencies. Longer time value indicates insufficient clotting factors and overactivity of clotting inhibitory therapy. So, when you see a clotting factor that is prolonged, you will know that they are having thinner blood and having a higher risk for bleeding. Okay, you will see this can happen with Coumadin, warfarin, and aspirin therapies. Now let's talk a little bit about bone marrow examinations. We are just going to lightly hit on this because you will be receiving more instruction on this from Miss Lindsay as well when you get into your hematology chapter. Evaluation of bone marrow, evaluation for unexplained peripheral blood cytopenias. They also evaluate with bone marrow exams for unexplained excessive peripheral blood cell counts. For staging and analysis of leukemias and lymphomas, they evaluate fevers of unknown origins. They can evaluate the patient's iron stores when other tests are ambiguous. They can obtain from they are obtained from the posterior superior iliac spine of the pelvis or from the sternum under local anesthesia. The nursing considerations, you need to make sure that you apply a small gauze square with mild pressure to prevent bleeding post-procedure and assess for any pain and bleeding. Now let's talk about gerontological considerations. The older adults are more vulnerable to possible problems with clotting, oxygen transport, and fighting infection, especially during periods of increased demand. Aging changes do not usually occur with the white blood cell count or the platelet count. Anemia is usually caused by disease processes in other systems as opposed to the hematologic system in the older adult, like they have GI bleeds or malnutrition. Think of the changes in the parameters that are solely due to aging may result in an incorrect interpretation of any laboratory test, which can then lead to incorrect management of your problem. So you need to look beyond just their age. Now let's talk about health promotion. Eating a well-balanced diet rich in iron, vitamin B12, and protein supplies bone marrow with the building blocks for blood cells. Individuals can do a great deal to maximize and optimize their health of their hematologic system. Like I said, eating that well-balanced diet that's rich in iron, B12, and protein ensures that the bone marrow supply for the requisite building blocks of blood cells are there. Exercise is critical for maintaining a healthy hematologic system, both because it encourages production of blood cells from the marrow and because it reduces the risk of cardiovascular disease. Excessive alcohol consumption damages the hematologic system on several fronts. It impairs nutrition because beneficial calories are substituted for alcohol. It damages the GI tract, resulting in bleeding and impaired absorption of B12, iron, and folate. And it damages the liver, resulting in decreased coagulation factors and erythrocyte production. The nurse can play a critical role in identifying opportunities to promote lifestyles that ensure the health of the hematologic system. You need to advise them on their diet and any contributing factors that they have for anemias. Thank you very much, and that is the end of this presentation. If you have any questions, please feel free to contact me either here in my office by phone. You have my cell phone number, or you can even text me at my cell phone.